Welcome to this episode of the Open Wound Research Podcast. My name is Willie Tuniswa, CEO of Open Wound Research and presenter of the podcast. Today, I am very excited to have a guest all the way from my home country of South Africa, and that is Liezl Naude. Liezl, it's a pleasure to have you on the podcast.
It's a pleasure to be here. I'm so excited just to chat with you about everything today.
Likewise. I think it's going to be a great experience for the viewers who are predominantly in the US to get a view of the South African wound care situation. And I just think it's going to be a great episode. Let me do a quick introduction with an overview of Liezl and some of her accomplishments. And she's very prodigious for people who don't know anything about Liezl. Liezl is a clinical nurse specialist in advanced wound care in South Africa. She is located in the north of the country in a city called Pretoria, which is just to the north of Johannesburg. Beautiful part of the country, the famous jacaranda trees, and home of the Blue Bulls rugby team. Her education, her education, she received it from the University of Pretoria, where she did her undergrad, and then she also did her master's degree from the University of Pretoria in community health nursing. She is a founding member of the Wound Healing Association of Southern Africa and the official journal of Wound Healing Southern Africa. She also sits on editorial boards at the International Wound Journal and the Wound Healing South Africa Journal. She's a founding member of the advisory panel for the World Alliance of Wound and Lymphedema Care and has been involved in the development of practical training programs, collaborations with multiple organizations, both in Africa and abroad, with more specific attention to the Middle East and the Far East as well. She's well known in various conferences. She's spoken at UMA, the Congress of Wound Healing Societies, and various conferences strewn across the globe. That's quite a mouthful, Liezl. You've done quite a bit in your career.
It seems daunting when you put it like that.
Let's start at the beginning. So you grew up in Pretoria. Is that where you grew up as well?
Actually, no, I grew up on a farm further north in the country, so I'm a farm girl in Hoedspruit, so a very small little town. Now, if you want to bypass the chicken, you will miss the town. Well, when I grew up there, now it's a bigger town. And I moved to the city centre Pretoria, which has been my home now for probably the last, let's say, about 30 years into Pretoria. And this is where I started studying. This is where everything started for me in wound care and in nursing. If you would have told me that nursing would evolve so much, as I've seen throughout the years, I would have never thought that I would do this. I'm allowed to do what I love, which is education, but also practical hands on treatment of patients. And I think there's so much in nursing that we underestimate and that we don't realize what we can do. Nursing has opened up the world for me. Wound care, even more so. It allowed me to meet people like you, my colleagues in the US, UK, everywhere across the globe. It allowed me to travel. So, from a humble beginning as a student in Pretoria, I ended up staying in Pretoria. And I love it here.
It's beautiful. I don't blame you at all. I've visited you twice now, and I'm always impressed by how beautiful the city is. So you grew up on the farm. What drew you towards science? Was there some family history, or what kind of attracted you to the science and the nursing?
It's actually very funny. I actually wanted to be an actress, believe it or not. And I actually had a bursary that I was going to study acting, and my father said on the farm over his dead body, will I go and do acting? I then was sort of like, okay, I love to work with people. What can I do about that? And then I just decided, okay, well, start nursing. And the course was challenging. I did the 4-year degree. So we had midwifery, psychiatry, community nursing, all of that enrolled in once. And that's probably where the love for everything started, doing research even on a pre-graduate level, which actually made me go into my master's degree. And that has drawn me further. Wound care is something that I think picked me, not the other way around. Even as a student, it was something that I loved. I loved the challenge of making sure that the patient gets the best treatment, making sure that communication between the different doctors works. I had an opportunity as a third year student, I think. I was working in a septic ward, and it was very difficult wounds, both legs of the patient. And I remember the plastic surgeon, I would have just done the wounds. And I left for a tea break or something because I worked almost 3 hours on this patient. And he came in and he took off all my bandages. And of course, being who I am, I did not stay quiet, even though he was the plastic surgeon and head of the department. I actually indicated to the sister in charge, please, when they come in next time, before they even open up the dressings, they need to read my chart because I've written everything down. And if he then wants to open it, it's fine. But first, read what I've written. So actually, next time when he came in for the wound round, he did read my chart and he called me in and he said, no, he won't open it again, but can I work with every one of his patients in future? So I think that's just where it started. And it developed from there on. Even when I finished my studying, everywhere that I worked, I sort of tended to the wounds. Ironically, when I started my own practice in 2000, I said I'm going to do everything but wounds because there are enough wound care practitioners in South Africa. That was probably the last famous words that I said because in 2003, we started with talks about having a joint wound healing association for Southern Africa. And of course, I was very young at that point, and maybe that's the enthusiasm of being young. At that stage, there was a nursing sister that was driving the Wound Nursing Association, and there was the plastics who drove the Doctors Association. And I was actually told I can't come to the meeting because I don't have the credentials. And so I decided I'll invite myself then. So when it was this meeting, I actually went to the meeting and I remember I walked through the door and that specific nurse was very upset because she saw me, what am I doing there? And I walked straight up to one of my mentors, Frans Cronje, and I said to him, hi, I'm Liezl Naude. And he said, well, I'm Frans Cronje. I said, well, I'm here to stay. How can I help you? And he just looked at me and said, okay, Liezl, that's good to know. We'll talk. And that was the last, probably history. So I then got involved with the Wind Healing Association, and the rest is almost just like a story. So the first actual conference that I attended was the inaugurational conference of the Wind Healing Southern Africa Association in 2005, which I helped organize. So that's where my journey in wound care started.
That's brilliant. I think with my time that I've spent with you, you've got a very forceful personality and you really try to do the right thing. And so it's not surprising to me that France understood or Dr. Cranier understood that you weren't going anywhere.
No, and years later, we were talking about how would he get me to do things, or how would he get me to do things that other people are not able to do. He will just tell me that it's not possible, and then I will go and do that. So he said to me, "No, we can't do a wound journal. It's not possible. There's not something like that in South Africa, and it's very difficult. And no, we've got a journal." And we were laughing about that. So he knows my strong points, my weak points, and he used them very well to get things going in the association. But that's part of mentoring, it's part of growing, it's part of who I am and who I've become.
No, that's brilliant. So it's 2000, 2005. The association's created. What were you guys seeing, or what were you seeing in how wound care was being done in South Africa, both from a sort of a practical perspective, care for patients, and also from an educational perspective, that is educating the clinical staff providers on wound care? So what was going on around that time from 2000, 2005?
I think around that time it was very similar to where we are now post COVID. It's sort of for me as if we're starting again now post COVID. I remember in that time the biggest challenge that we faced was education. Is people not being educated about wound care skills definitely was a big problem. And then getting the word out to working together as a team, that multidisciplinary approach. And we started the Wound Healing Association at that point in time with this whole concept in mind of making it multidisciplinary. Get people from different disciplines to talk wounds, because once you've got the different disciplines respecting each other, that's when you move forward. And we had a very good start initially in wound healing and in the association. We had on the board, we had podiatrists, we had nurses, surgeons, plastic surgeons, vascular surgeons, hyperbaric physicians, GPs. It was really a time where people pulled together and started working together in changing things in South Africa. And we also had quite a few, obviously, a lot of buy in from trade in supporting the organization. And I think one of the great things that we did in those years, we had a 10-year plan. In hindsight, I should have made it a 20-year plan. And you sort of like, we were thinking, okay, for the next 10 years, this is keep the organization going, and then it should be going on its own 2 feet and be able to be strong enough. But one thing that I've learned through that is where we did make a difference was that continuous education and get that started in both public and private sector. That was the real beauty of where we started in 2005, getting that public private working together, get the education through all of the different provinces.
And so, just by way of background, again, given that most of our audience is going to be American, could you describe what the nursing system, education is, or the healthcare system in South Africa between private and public so that people can get an idea of what that system looks like?
So South Africa has a very unique setup. We've got our private hospitals, and we've got a private medical aid funding system where patients pay their medical aids and claim back with reimbursement from them. We do not have a national healthcare system as of yet. It's coming, but we don't have that. And then we've got the government system, which is the public system where most of the population of South Africa have to go for their wound care. The biggest challenge that we face currently, if we compare, if I can talk about public and private as it is now, is there's not a big difference between the two. Both systems are not in a good state in South Africa currently. There are certain hospitals that do very well, but we have a problem with specifically the nursing care in South Africa. So there are these pockets where there's great nursing, great wound care. The overall treatment of the patient is absolutely wonderful, but then also we've got these horrific stories of not having enough trained staff, very similar to what we see across the globe. This is specifically post-COVID, we see that even more. And there's a definite gap in education and skills development. So in South Africa currently, if you look at the nursing population, a lot of our older nurses are now leaving the system. And there's a gap. We've got a lot of young nurses which do not have the skill and the knowledge to actually make the decisions because the curriculum has changed so much with nursing in the last few years. And then you've got this gap where there's almost no nurses and the older generation moving out. So the big challenge for South Africa is retaining of qualified personnel and nurses, but also the gap of the new nurses coming through that's been trained not with different new colleges and so forth. Are they training actually up to the right standard? If I look currently, I've been doing wound care training and education since 2005, where I've trained students in the Eloquent Learning Health program. And we've seen over the years that your baseline has actually gotten lower. You need to start with a lot more basic wound care training than what we did previous years. So there's a huge need to make sure that your basic wound care, your basic level of nursing is upskilled. And it's also a problem with us in South Africa because what they've done is they've brought over a bridging course between the different categories. And if you do a bridging course, you tend to lose a lot of the key knowledge that is through the full program. And we see that in practice, where a lot of these nurses are struggling. And that makes it a bit complicated in South Africa. I've learned, and I don't know if that's the case in the US, but I've learned that being a nurse, we've got these epaulets with the bars on to say how you've been qualified and what you've done. Um, but the bars don't tell you exactly how good a nurse it is. It's the experience and how they actually do in practice. Because as you know, I mean, you can do very good in theory, but how do you take the theory and put it actually into practice along the bedside of the patient? And I think the big challenge for us in South Africa currently is to make sure that we maintain excellence, and with the new programs that everyone is actually skilled up and not skilled down.
Now, that absolutely makes sense. And that's on the physician side. From your experience, have physicians gotten better at wound care, more knowledgeable on average, or how has that developed?
I'll give you the honest answer. No. I mean, years ago, the time that I spent with medical students was 1 hour to train them wound care. in their third or fourth year. That's not wound care training. Most of our medical practitioners learn after they've done their courses what they do in practice. And the challenge with this is as well, if they've been taught by a professor or a registrar one way, for instance, dry gauze is still the best way, betadine is still the best way, they're not always open for anything new. I had a very interesting conversation with a vascular surgeon a while back with regards to a patient. When he wrote me, the patient actually saw me first. He did the vascular examination, and then he wrote me a script to tell me I need to either use a 4-layer bandage system or a 2-layer bandage system. And when I saw the patient, I actually saw this patient actually still has infection. I want to add an antimicrobial with the compression. I've got no problem with the compression, but I'm not going to leave it for a week. I need to go at least 2 times during the week to make sure this patient is okay. So I saw the patient in the meantime, saw the patient then just before the patient was going to see him, write a full report. And so he phoned me up and said, who am I to change his prescription? And I said to him, well, I've got more than 25 years in the field of wound care, number one, and it's according to evidence-based practice, the International Infection Control Guidelines states that we need to treat the infection. And he said to him, and he then pulls the Cochrane database and says, now Cochrane says that you don't need any antimicrobial. Long story short. And then I said to him, well, that's great news to hear, but I would love to see your database and your articles that you give them. I'll give you mine and let's share that. And then we see who's going to work where and see that. So we obviously at the end, he acknowledges what I do, and we got the patient healed very quickly with all of that. But it showed me that mindsets often that we see with the different disciplines, having the medical practitioners on one side, the specialists on one side, is that we don't know what each other are doing and don't understand. And even though you know about compression bandage systems, if you don't do wound care on a daily basis or is actively busy doing wounds and seeing wounds, you tend to forget how to apply that theory and that evidence. Because it's one thing to read the literature, it's a different thing to apply that to practice.
And most of that literature is coming from Europe or the United States, which carries its own assumptions.
Exactly. Africa is different. We, just to give you one example, look at the temperatures in Europe versus Africa. Your silicone dressings in Europe does very well. In South Africa, if it's in the heat season or it's in a humid area like in KwaZulu-Natal, those silicone dressings don't last that long. We need to work differently with that. So you can't always just go with what's been all the research done in one country or one setting. You need to look at what's happening on countries similar to yours. What's their experience?
Let's walk down that road a little bit. So you've been abroad, you've talked, you read the research. What are the really different things about practice in South Africa versus the United States or Europe? Like heavily resourced countries. What's the difference in South Africa that you see as sort of the biggest component outside of, let's say, weather or treatment of products?
South Africa is in a very fortunate place. Um, in one sense that we have access to a lot of products that even America does not have, because we don't have all the legislation that you guys in the US have, the red tape, if I can put it like that. It's also the detrimental effect to the country, because a lot of the time products gets dumped here, or we are used as the research part to evaluate products where it's easier and cheaper to evaluate and then give the feedback back to the rest of the world. I think the biggest difference for me with how we in Africa do wounds is we improvise a lot. You will look at a product one way and think of 30 other ways of how you can use the one product to get a good result, irrespective of what it's been prescribed for, which means that we are really innovative in the way that we use products and what we use as material together with products. So if you don't have something that you can put at the edge of the bed to relieve the pressure of the linen, you will take a cardboard box and put that there. And especially in the winter, that actually saves the temperatures stay nice and warm better than a clinical steel framework. That's the irony of it. But we certainly in South Africa have a problem with not always having access to the products. So what you will have, especially in the private sector, because they've got tenders and they've got certain products that are available, I'm almost saying that it's more difficult sometimes in the private sector to get the real advanced products than in the public sector. Because the public sector, I can walk into a storeroom in one of the state hospitals and actually see not one, a lot of the best wound care products out there. And at the same time, they will have the cheap China or the knockoffs that you can get there that's absolutely no value at all. But they will have both of them. And the challenge in South Africa is that I think we, as a country, we're a dump for a lot of products. And because of the, unfortunately, the corruption in our healthcare system. So it's not about getting the best product in, it's getting the kickback probably, or how much, who do you know to get your product into the country and to get that done. And I think that's a pity in our country at the moment. But bearing in mind with that, that also gives us the opportunity to get our hands on products that others don't. I'm very fortunate in a private setting. I am using products like Granulox, a topical hemoglobin spray. I'm using Actigraft, which is a whole blood clot therapy. I am using intermittent vacuum therapy as part of my practice. So, and these are all very advanced wound care devices and treatment devices. So you've got in South Africa the beauty of having first and third world in one. And it's about creating that balance to see how you can work to treat the patients who don't have money as well as the patients who do have the money. And that's, I think, everywhere in the world challenge, not only here.
So let me ask you, in your practice over the past 20 odd years, how it's drilling down in the sort of distinction between the first world and the third world in one country. In the townships, and just for the audience, the townships are usually on the outskirts of big cities. They tend to be poorer on average than the city, and people just can't afford services for the most part. What has your interaction been with the third world component of wound care in South Africa? And how have you kind of dealt with those concerns?
So the great thing about that setup is with the public hospitals and the clinics is even though I'm in the private sector, I do work with the public hospitals. So I'll have patients that have no medical aids, but we work directly with the with the public hospitals and with their wound care units to say, okay, if we work together, let's see if they can get the products maybe from you. I can assist with some of the treatment. And a lot of my colleagues do the same thing if we're working in private to literally assist the public sector in that way. Our public sectors, especially the tertiary hospitals, are really well geared. They do have access. And I often think the patients at the public sector almost get a better treatment than at even the private hospital. Even though there's volumes with both, in the private sector, you're often restricted with the products that you can use because at that hospital, they're only keeping these products. Where the public sector, you've got access actually to more products. So you've got a variety that you can at least access to. And it's not to say that you're not going to wait in long lines in the private sector these days. It's sort of to me almost as if the two is sort of like maybe it's the move towards the national health system that they're all talking about. I don't know. I don't think personally our country is ready for something like that at all at this point of time. And there's a lot of practitioners who are in private practice who are really worried about what's going to happen to all our patients, who's going to be able to see who, and those type of things. So those are challenges coming up very soon for South Africa. But I think when we work with and I've got patients coming from townships as well and from rural areas. What is great about South Africa, and I still believe in the Ubuntu concept. We did a conference in 2010 called the Ubuntu Conference. And I still believe from that whole conference, Ubuntu is not dead in South Africa. I still believe it's here. I still believe we actually do care about people and we care about working together and we want to make a difference as South Africans. If you look at the general population, that's still the feel that I get when I work with my patients. I mean, I've seen a patient today that is actually coming from Nelspruit, which is quite a few hours drive from where I am in Pretoria, but they bring him here because the family is putting the funds together to help and see if we can't get this patient better, even though he's not on a medical aid. And I see that with a lot of patients where family and friends actually assist with the care. Yes, we've got our bad systems. We've got in hospitals not qualified staff who don't know about wound care, who still believes if I put the gauze on, the patient will be fine. And that's unfortunately part of the problem. I think my dream and why I started Eloquent Learning Health was really to change that through education, to train more people so that we can help more people. Because once people understand wound care and they think wound care, that's when we make a difference. It's not just about the wound, it's about the patient, that holistic care, the family, everything about that patient. That's where we make a difference.
I mean, at the end of the day, that patient centered care concept is
Mm,
universal. You know, that patient is the focus and should be the focus of care.
mm.
What kind of wounds are you dealing with on average? Again, I know it's dependent on the population you see, but what are the kind of wounds that you see most often? Are you dealing with a lot of pressure ulcers? Do you see a lot of those? Give us an idea of what kind of comes across your clinical view.
So, just speaking of today's patients, and that's unfortunately the thing that we see with the hospital care not being as we would like it to see, is the increase in pressure ulcers. So I've seen two patients today, one with four pressure ulcers and one with one pressure ulcer, which is all avoidable pressure ulcers. So that's increased for me. I do see a lot of diabetic foot ulcers and leg ulcers. My clinic is more known for me treating the diabetic foot and the vascular ulcers. I specialize in complicated wounds. So I see cancer wounds, and also post-surgical dehiscence is something that I see quite often. But probably mainly with me. Oh, and then skin tears a lot. That's surprising actually. With the ISTAP and the new documentation just coming out, I don't know if I just happened to see more of them, but I've had two cases this week, and one case is quite severe that I saw yesterday. This patient had six skin tears and more almost like a laceration than a skin tear. So I do see a lot of trauma cases in the elderly, which is I wonder if that's globally a thing. Patients, because they're getting older, they fall more, they bump themselves more, so you tend to get these type of wounds. And if they're on an anticoagulant, of course, that's just a nightmare. And also that I don't think the general public actually knows how to deal with skin tears. There's a huge educational gap for both the medical practitioners and the public.
It sounds like it's pretty varied. I mean, the pressure ulcer prevalence and incidence seems to be going up across the board. That's a big area of concern in Europe. There's a journal out there that's looking to do a whole issue just on pressure ulcers next year. And in the US, it's as the population is growing older, the number of pressure
Yeah,
ulcers are increasing, and that's very expensive, as you know. So it's interesting to hear that in South Africa that you're seeing more of that than you saw
yeah.
before. And when I visit home, what catches my eye, and I saw you in March, is that I look at people's legs now. Just look at people's legs as you walk through the malls, and you're like, oh my goodness. you know, you've got people
Yeah,
who obviously
it's a
have
terrible
issues.
hobby to have.
Oh,
It's a
it's
terrible hobby to have.
yeah, no, it's scary, and then our obesity rates are also going through the roof. You know, so
But that's
it's
the thing, Zoe. Have you not seen, well, with obesity currently increasing so much, your leg ulcers has just increased tremendously. Lymphedema. I mean, I have more lymphedema cases in my practice than I've ever had before. And it's part of also with the obesity. And then together with that, you get the diabetes factor. So we see literally, I think over the realm in chronic wounds, we are seeing an increase in all chronic wounds. And it's probably due to lifestyle as well, which one of them is we've got an older population. But the obesity factor definitely, I believe, is playing an immense role. And I can see that in my practice. And it's younger people that struggle. It's not necessarily, if you look at diabetes, my patients are getting younger and younger with diabetes. It's not like we've seen previously. We think about an older generation who have diabetes. And also the complications, the amputations. One thing in South Africa that I think is alarming is our amputation rates. I don't have clear numbers. We don't have those statistics. But I work next to an orthotist, and I can tell you that his practice is doing very well making legs for people.
That is concerning.
Mm.
That's a major concern in the US as well. The statistics on amputation in the United States is concerning, but it's very geographic. There's a lot of geographic variation.
The same in South
But
Africa.
so let's go down that road real quick. So in terms of peripheral arterial disease, a lot of these factors that go into patients actually getting wounds, right? Because a wound is a function of a bunch of different factors. What is being done, or what are you seeing being done upstream to try to treat patients better and treat these underlying conditions? Is it a case of just dealing with it at the end stage, or has there been movement to try to resolve that upstream?
It depends where you are and which hospitals and which areas. So it's very, like you say, geographical to see if you've got a team that is driven to actually make sure that the population check their vascular status, make sure about them managing right, then you can see the difference. But if there's not enough manpower, there's no people driving that, what we see, it's easier to amputate the leg than actually to try and save it. But the problem is, if you look at our teaching hospitals, you want to give students as much exposure to different procedures and sort of that, all of that. And if there's a shortage of beds, you are not going to sit with a wound that's not healing forever and ever and keep that bed occupied. It's easier to amputate. Number one, it's a learning opportunity for the surgeons to know how to do that. You're saving a bed, you're getting the patient out of the hospital sooner. The problem is with that is being if it's in a public hospital, the resource to get that patient a new leg or prosthesis is a long waiting period. So that patient develops other complications, which in general, that's not being thought about. It's only what's now. Okay, I need that bed. Rather amputate this leg. It's not worth our while to go and treat that leg. And I've seen that a lot of times over the past few years because I'm known as a limb salvaging clinic. So patients do seek our clinic as the last resort when they've been told in hospital they need to amputate. They will finally come to us and say, can you save this limb or not? And we've been very fortunate through the technology that I have available at the center and through the way that we treat the patients to save quite a few limbs over the years. And that's probably what makes me tick as well to get that done. But we have a challenge in South Africa to really get people to understand that if your top level is not involved with these uh, applying international protocols and evidence-based teachings, we actually are losing lives, we're losing limbs because of that. And I think it would be frightening if we go and see the real statistics. COVID was one of the things that actually sped up the amputation rate because of what the disease did. But it seems to me, if I look in practice at the moment, because that happened in COVID, people are just continuing with the same practice. It's not as if we're reining in and say, okay, guys, COVID's now over. Let's just get some sanity again going on. Maybe we can save this limb rather than amputate it. And it might be a very controversial statement to make, but that's something that I've been seeing in my practice. It's as if we've gone off the one end post COVID or during COVID, and we're not recovering. We're keeping in the same mode. I don't know if you experienced that in the US.
There's been a malaise in different areas. Again, a lot of geographic variation. But the malaise in the United States, in nursing homes, for example, the staffing, they just cannot find
Mm.
staff, right? So wound care, I wrote an article a couple of years back that showed COVID and the rate of pressure ulcers taking off at a national level, and it just was startling. It jumped off the page. It's stabilized a little bit, but staffing, it's highly contingent on staffing, and that issue is still ongoing. I do think that there's been a resurgence in the American wound care market, more interest. There's been more groups that have been forming. There's been more product going into the space. There's been a lot of resources that's been going on post COVID. So it's very unlike South Africa in that way. But when I visited in March and we spoke, and you can see that there is a malaise going on in the healthcare system in South Africa post COVID.
malaise is the right word for that. Actually, it's almost like we're just continuing on. There's no urgency. I almost like to say you can make a difference, even if it's just changing the patient's position. That's fine. You don't have to just stand there. Do something. It's so important to just do something and actually make that connection and do it differently. The biggest problem I think globally always is that complacency of we've done it all this time like this. Why should we change? Why do we need to change? Um, and if we're at that point, I mean, the only constant thing in life is change. So if you're not going to change, how are you going to move forward? What's going to happen with your patients? Because if we don't actually involve them also in the treatment plans, and I think that's one thing that's to me a bit of what I see in private practice is that with a lot of patients, they are being treated and they're treated quite well with their wounds. Sometimes not, sometimes they do. But often the patient don't even know what the nurse has used. They can't tell you which product was used. They can't tell you why. They just said, okay, well, but I visit them 3 times a week and it's not getting better. My question is, why didn't it get better? Did you check? I always love to talk about VIP. And it's not a very important person VIP. Not that you are not very important, really. You are a VIP in my book. But it's a different VIP. It's vascular, the V for vascular, I for infection or inflammation, and P for pressure. And I firmly believe that is what wound care is all about. If you don't check the vascular status in your patient, how are you going to know if this patient's going to heal? If you don't treat that, either doing vascular surgery or promoting the blood flow through various treatment modalities that you can try and use, even as simple as teaching the patient to start walking again, that's going to improve blood flow. Infection and inflammation, if you don't treat it, that wound's never going to heal. It's going to be an ongoing battle. And then pressure. And the pressure goes both ways. Pressure like in pressure ulcers and diabetic foot ulcers where there's too much pressure. And then in a venous leg ulcer where there's not enough pressure. So with that, if you keep that in mind with every patient that you see and you just go through VIP, we can make a difference. And I think what we've been doing is we've overcomplicated wound care. So how many times at a conference, it's all these scientific papers. But what do people really want? What do people really need? They need to know, how can I apply that research to my patient now that I'm sitting next to the bed with this complicated Charcot foot and diabetic foot ulcer? How can I take that and work it into my practice and to help my patient? If I'm sitting in Africa under a tree and I've got nothing, but my neighbor's got a beehive in his backyard, and at least I could get some cloth material, so forth. I've got a bandage system. I've got an antimicrobial dressing because I've got honey, and I've got a bandage system. So it's those kind of things is that we need to think, and how can I make it practical? How can I? And I love that because the Australians are also very good with that. They do a lot of work on natural remedies, natural resources that you can use in wound care. That's something that every country has. Every country has their natural resources, their stories about how the natives have used this and that. And I think where we are in wound care is we're going back to those roots as well, because we know our antibiotics are not working as well as they did before. But we do know that if we keep to the basics, we make a difference. And COVID has taught me a few things. Because during COVID, resources were so scarce, even though I was part of a private center, I had to improvise. And sometimes all that we did have to treat wounds was hypochlorous solution and gauze. And believe me, that can still work, or acetic acid. So that may seem like nothing, but you can still make it work.
When I was down there, you shared with me about these kits that you would put together, these basically these jump packs that you could use to treat people in areas where things were challenging. I've also seen you treat elephants, but we'll ask that question a little bit later. Tell me, can you share with the audience a little bit about the motivation behind these jump kits? Some very simple jump kits that could be used in under-resourced areas, and why did you create them, how are they used, and what effect have they had?
So this is a beautiful initiative actually from the World Alliance of Wound and Lymphedema Care. So, as an international organization, we've actually got Professor John MacDonald and Terence as well. They're working with the kids and Huber from Europe, from Geneva. So it's US and Europe as well as Australians all across the globe that work together on getting this kit sorted. It's also greatly supported by UMA. We've done a lot of work together with them, and that kit it's available on the World Alliance site, so you can see what's in the kit. But you can do with that kit 50 wounds at least. It's got the basics in gauze, bandages, basic supplies. There's antimicrobials in there. There's dressings in there, but it's made in such a way that depending on where you are in which country, it can be replenished by the country itself. So it's not completely foreign things that in there. To give you an example, instead of putting Gelinet, for instance, in the kit, it's a Vaseline tube and gauze. So you make your own Gelinet gauze. Because if there's a lot of heat in the environment that you're working in, it's better to actually have the two separate than to actually waste all the petroleum going not being dissolved or leaked out or something like that. So there's been a lot of care gone into the kits to make it, and it's also very sturdy. There's actually photographs of that on the website as well. It's a box, so you can put it on the back of a motorcycle or a cycle and take it to the ruralist of rural areas that you can work there. And it came from actually what happened in Haiti a lot of years ago, prior to 2010, actually, where we realized in a disaster area, what happens globally is you've got all these organizations and companies who would sponsor equipment and products, but it's in these large containers. And often, when people start opening up containers, you are confronted with this large amount of dressings, which you don't know where it goes and what to treat with. And those often expire or get damaged. Well, if you have a box that's got everything in there that you can treat patients with, you just take out the box and you can treat any wound on site with that. And that makes it a lot easier in these type of disaster areas or low resource settings. My dream still for that kit is to have that and to use that in South Africa and in Africa as a starter kit for wound care practices in rural communities and working together with the local community to teach them how can they replenish the kit themselves. In Africa, I think a lot of the time the globe, the US, all of that, think that in Africa, things just need to get dumped in Africa. We're going to help the Africans. We are going to donate this and donate that. It's not about donating things. It's about teaching people how to do it themselves. It's about equipping them with the skills and knowledge to actually do it themselves. And we can see that happening currently in Africa. There's a lot of good things. If you just go and you look in Kenya and Uganda, everywhere up in Africa where people are actually taking care of themselves, starting their own programs. Tanzania is another example of that. And I think globally, if we understand that it's not about we can't do anything for ourselves in Africa, we need help. Every country needs help. I've worked across the globe. I've seen low resource settings in Canada. I've seen low resource settings in Germany. And at the same time, just next door, it will be the first world setting. So we've got third and first world in all the countries across the globe. The difference is where we see things change is if we teach the local community to take responsibility and empower them to start their own practices and to start their own clinics. And those are the things where we do really get change to happen, not by donating just stock and donating things. It's it's that age-old saying that says you can give people fish, but if you teach a guy to fish, he can feed the family, the community. And it's not just giving them. Going
That
off topic completely.
No, this is great. I mean, I think the perspective you bring is so novel that we kind of have to ground people a little bit in what we're talking about.
Mm.
And this is brilliant. I myself, I'm learning, and I am South African, so it's kind of interesting what you're saying. So, in terms of ways that the international wound care community, international wound care experts, etc., can help countries like South Africa is less giving product per se, but more about giving knowledge and skills transfer.
Improving skills as well. I think that's globally a thing that's so important. And skills is not the advanced skills. That's the pinnacle. You want to empower the youth, the general public, all of them to actually be able to recognize what can I do with, because there's not enough nurses, there are not enough wound carers out there. But why can't we work with the families and the caregivers, because they're already doing a lot of the wounds. I mean, a lot of families are taking care of their family members. And I believe we need that grassroots education still. We said that that was part of the start of the Wound Healing Association. We did these grassroots conferences, but I think you can never really stop with that, because there's always a new generation coming in. There's always new people that know nothing about wound care, but they had a family member that was ill, and then they realized, okay, but you know what? I want to make a difference. How can I get involved in this? And to take hands of that community. I'm not saying that you're taking away from the wound care specialist or the advanced wound care practitioner, but we can actually equip family members and care workers to be the hands and feet and to help the advanced nurse more so. In other words, that these type of settings can do the basic wound care. And when it's really complicated, can be then referred to an advanced or a specialized wound care specialist, because there's more than enough wounds out there. There are such a great need just in South Africa for wound care that it blows my mind actually on a daily basis. You see so many new practitioners starting up their clinics. And I think there's a huge need for us in South Africa to assist these new practices and we call them newbies, new wound care practitioners, to assist the newbies. But I don't know if you have that in the US. There's this professional jealousy often, where the practices that's been large practices, being a long time in practice, don't really want to share their knowledge because they feel threatened by the newer person coming in. And I actually believe that's just a mindset change, because we can learn from each other and we can work as teams. And that's one thing. If globally we want to make an impact in countries like South Africa, in Africa per se, it means that we need to go onto the grassroots level. We need to make sure that people understand the basic principles of wound care, improve skills. How do I identify the wound? What am I looking at? Why is this wound there? I think those are the key things that I see we really need to work on, is those diagnostics and saying, okay, but if this is not working, I'm not going to go on with the care for 2 months, 3 months. I'd rather refer them to somebody and get that network going. That's when we really get change ongoing. And I also believe part of these podcasts, what you're doing is also that educational component where people can actually listen and watch a podcast and learn from that. We underestimate the value of social media and all the media that's out there in education. Because if you look at what general patients do, Google can be your friend or your enemy. And I mean, I have a lot of patients that will come to me and say, Google said this is actually gangrene. And I'm, did Google study? Which Google are you referring to? So it can be detrimental as well, but it also challenges the practitioner to have that evidence-based feedback, to say to the patient, I am using this type of product because it does A, B, C, and D. And this is what I expect to see at the end. And a lot of practitioners, and that is not only nurses, it's medical doctors, it's surgeons, don't understand products. They don't understand the wound care products, how they work, how they interact. So there's a huge educational point where we need to do that. We need to educate people about how do they apply the product. A simple thing. How do you stick down a plaster? Where do you start? Do you take both of the sides of the plaster off? Do you stick it down in the middle? All those kind of things. And those are practical things that people need to know, because that makes a difference.
Absolutely. I think I have a mission to being South African, being my my home country, is really showcasing people like you and saying these are the people that are doing what we do in the U.S. international in their own communities. There's different challenges, but also trying to get some of these amazing people that I know to come down, help, educate, support. I just think, you know, there's so much opportunity to do great things.
That's why I started Heart for the Wounded, what, 10 odd years ago. That's the conference initiative, that one of the conference initiatives we have in South Africa. And Heart for the Wounded was built around the fact that it was very selfish maybe in the beginning, because I wanted to get speakers in so that I can learn more. That's been probably how I've been doing conferences my whole life and events, is I want to know more about this. Who can I get that's an expert on the field to tell me more and where I can learn from? Been sort of my drive always of education. If I want to know it, I'm sure there's other people that would like to know more about that as well. So let's see. And Heart for the Wounded is probably part of that, where the whole slogan and the challenge of Heart for the Wounded has been all through the years is making a difference, be the difference. It's that theme of challenging individuals coming to the conference to say, how can I make a difference? What can I do? Can I take the knowledge that I've gained here and impact my community? That's when things happen. You can go to a lot of conferences, but if you can't take away from the conference something that's going to change your daily practice, why did you go? To have lunch? Not going to work.
We've got about 7 minutes left, and so I have two questions. This one should take most of the time, and then we have a very short one. So let's get into research real quick, because a fascinating thing that you've said, and something that I'm always been about, is how do we translate research to the real world, right? How do we choose research that makes sense for people giving care? And how do we have that treatment protocol or effect cascade through a system? So, what kind of research have you done? And how has that research impacted your work? Or, what kind of research has impacted the work?
So I'm probably very well known for product evaluations and really giving feedback about new products being developed and all of that, but also existing products. I've worked with products like whole black clot technology, which I do believe is a brilliant technology in enhancing wound healing and in practice impacting all of that. But I often believe when we do these studies, especially if it's a study from the US or from Europe in Africa, the cost of the product is for the US market or the European market, not for the South African market. So it's always great for me to do the research and to be. So I do that often, and that's probably a very selfish reason I do research, is because I can get free products for my patients. Because a lot of the times we get the products as part of the trial, which means I can treat patients that can't otherwise not afford this type of treatment and get an end result where the patient is better off and I can give feedback according to what's happening. Um, but the problem also with that is if you evaluate these kind of advanced technologies, take for instance now, a technology that now is starting to get a lot of attention in Europe, I don't know if it's in America as well, is called plasma treatment. And cold plasma treatment is actually quite expensive. So in South Africa, even though the study that I did, I think we did about 20 patients in the end, was very good results. But most people won't be able to afford paying that 3,000 Rand per application or per session. That starts getting quite expensive. So it's great to do research about products, but there's a big difference between, I think, the European and US market versus South Africa or Africa per se, and probably some of the other countries as well, because as you know, the South African rand is terrible at this point in time. I mean, 18 towards the one towards the USD. It's quite an expensive thing for us as South Africans. But what I love about research and what I love about using these type of products, and for instance, evaluating a new honey on the market is the impact that it can make in your patients. And I believe also in case series, because if you consistently through several cases see a positive result, that's beneficial. You don't always need a randomized control trial to see that something is working. And I think there's a shift in the medical fraternity to look more towards consensus documents and key opinion leaders rather than very expensive randomized controlled trials. And to be honest with you, I hate an RCT because I always, when you put that button on the computer to say which type of treatment the patient's going to get, the placebo or the real one, or the standard of care, I'm like, ach nee. I want to give them that treatment. I don't want to give them. And I think that's the ethical thing for all of us in research is when you have to do that double blinded where double blinded's okay, but when you know actually they could have gotten this and they can't because it was according to the study, it makes it very difficult. And I often found when I can just do a peer case series about how do different wounds react to a product and see the benefit from that. That has been the most beneficial, not only for my patients, but also in explaining to medical aides how a product works. We've recently did a case series on Nitrox, the oxygen device. So that's now currently available also in South Africa. It's been authorized now by one of the major medical aids, which is quite a breakthrough, and it's more affordable. So there are definitely there it was worth our while to do the case series to get that actually recognized and get the medical aids to actually see the difference that it makes in a patient's life.
No, that's brilliant. We've got about 2 minutes to go. So, a question that I've asked every guest at the end, and I think we have to have you on again because it's just so much that we need to talk about. But for this episode, if you could get a wound genie, right, to grant you one wish, and to solve a problem or a challenge you have in wound care at the macro level, what would that be?
My wish, affordable, quality wound care driven by good education.
I love that answer. It's so practical. I love how practical you are. I think we need to have you on again. I think, again, I'm a little selfish. South Africa, my home, and I'm an American as well. But I think that conversations like this are really valuable. And it's one of the reasons that we started this podcast because it's just amazing people all throughout wound care, all throughout the world, with so much to share and so much insight. And I just appreciate the time and I appreciate the work you do. When I visited in March, I remember you helped save that gentleman's limb. And I remember him just happy, his family members happy, him giving you a hug, and just those victories that we can that we can get in wound care are just you guys change people's lives, and I'm just honored to be part of that and to share that with the rest of the world. So thank you for all the work you do, and thank you for being you.
Oh, thank you, Zweli. I can tell you one thing about it was actually rhinos that I've treated in February this year. And today they've sent me a picture of my rhino. She's almost completely healed. So
Oh,
I am
the
so
rhino
excited
has
about
healed.
that.
Okay. In closing,
Yeah, the wound is yeah, yeah. So I'm very excited. They are very happy. I'm very happy about that. It was just ironic, but when I was treating the rhinos, I actually got bitten by a tick. So I had tick bite fever this year, which
jeez.
was crazy. And to top that off, I was bitten by a violent spider also 6 weeks ago. So I'm living in Africa.
And just to clarify for people, a couple of weeks back, I saw Liesl's picture with her treating a rhino, literally a rhino.
Yeah.
She healed it apparently, so that's remarkable. And I bet you most wound care providers have not treated rhinos. So and you said earlier it was ironical, but I would say it's ironical. But with that in closing, thank you again for your time, and we'll bring you on again. I think this was absolutely brilliant.
Uh, it's an absolute pleasure. I enjoyed every minute of it. I mean, I love to chat with you, and I think, I can see how passionate you are as well as about what you're doing, and it makes a difference, really. Um, the wound care fraternity is a very special fraternity, and there's really so much that we can share. And having platforms like this makes it possible. And it just opens our minds to what our colleagues are doing and how we can tap into that and tap into those resources. And that's what's important. Networking is what makes the world go round. And you are giving us that opportunity. And thank you for that.
Thank you so much. I truly appreciate that. Well, in close, thank you so much, and thanks everyone for joining. And Liezl, we'll see you next time. Tot ziens.